Hello everyone, this is about a 15-year-old boy who underwent CT test before and after IV contrast due to his recurrent respiratory infection for the past 2 years. You can see the images and give the complete diagnosis. You can see especially the post-contrast images gives very important findings. Go through that. If you want more time, please pause the video and go back and see the images again. Are you ready? Okay. I'll give you the findings. There is a soft tissue density in the right lower zone, which is supplied by a thoraco-abdominal aorta. You can see mild degree of right pleural effusion. This has been drained by a pulmonary vein. The image is not given here. So the final diagnosis is very simple and very straightforward. It is intralobar pulmonary sequestration in the right lower lobe with mild degree of pleural effusion. Pulmonary sequestration is defined as a non-functioning abnormal pulmonary tissue not connected to the bronchial tree and is supplied by aorta. There are two types: intralobar sequestration, which is drained by pulmonary vein, whereas extralobar sequestration is drained by portal vein or other veins, not with the pulmonary vein. Now we will go to the embryological pattern of pulmonary development in relation with pulmonary vasculature. If you've got anomalies like abnormal lung and abnormal vasculature, we have got three categories, which can be intralobar sequestration or extralobar sequestration, or CCAM, which is now called as CPAM, congenital pulmonary airway malformation. Second one is where abnormal lung will be there with normal vasculature. So here we have got three types: congenital lobar emphysema, congenital lobar obstruction like bronchial atresia, and third one is bronchogenic cyst. Third one is normal lung with abnormal vasculature, so which has got aplastic or hyperplastic lung, scimitar syndrome, and AVM. Now we'll go to the differences between intralobar sequestration and extralobar sequestration. Intralobar sequestration is more common than the extralobar sequestration. Almost they say 3:1 or 4:1. So usually intralobar sequestration most likely due to post-infectious acquired one, but congenital intralobar sequestration also has also been there, and male is to female is almost the same, 50-50%, and usually the presentation will be in older children or young adults, usually almost half of the development within 20 years. Usually intralobar sequestration means inside lung and has no separate pleura, and most of the times it will be almost 75% due to lower lobes infection, with left being more importantly affected than right one, and recurrent infection is the presentation time. Arterial supply is usually by thoracic or abdominal aorta, as in this case thoracoabdominal aorta, or one of its branch, and it is always drained by pulmonary vein or veins. And what we have got is airless consolidation with or without few air or cystic spaces, and usually it doesn't have, intralobar sequestration usually doesn't have associated anomalies, which is less than 10% usually. Now we'll go to the extralobar sequestration. It is always congenital, and males are more affected, like 4:1. Fetuses, neonates, infants, or young children will be affected within 1 year usually, and outside lung has its own separate pleura, and 90% again in lower lobes, left being more affected than right, and focal lung mass is the presentation usually, and arterial supplied by abdominal aorta and usually drained by systemic veins, where either IVC or azygos and portal veins, and always airless unless communication with gastrointestinal tract. More frequently associated anomalies might be there. So the main important one is draining vein. So draining vein by pulmonary vein, it is almost always intralobar sequestration. It is drained by systemic vein, it is almost always extralobar sequestration, right? This has been given as a quiz, and it has been responded very well. So many consultants and residents responded to the quiz. I'll congratulate everyone. And there are so many superstars like Dr. Krishnaveni, Varsha Sarda, Kadar Baksh, Prashant, Dr. Deepika, Dr. Jayaraman, Dr. Chetan, and they are the superstars. And there are so many near superstars are also Dr. Pandiraja Lakshmi, Dr. Vanmati, Dr. Praveen, Dr. Daniel. They also responded correctly, except didn't give pleural effusion, which the patient came with pleurisy. Dr. Lakshmi Narayanan, Dr. Raghavi, Dr. Gopinath, Dr. J. Chandrabose, Dr. Madhumita are also near superstars, and shining stars are Dr. Balaji, Dr. Vijay Kumar Gujare, Dr. Shanmu Priya, Dr. Arpita. I thank everyone and all the best. Take care.